All right, we're going to get started here in just 1 second. I've got a couple of folks that we're going to bring on board. Let's see here. Let's see. I'm not certain if they can hear me yet. Let me stop that. Get through some technical issues. Ashton, are you on board?
Yes, I'm here.
Okay, there we go.
Okay. Hi, everyone. I'm Ashton Haynes here with Haynes Physical Therapy. I just wanted to go over a couple of things before we get started here. Luke is going to be our presenter. He is our PT and one of our owners. And there will be a spot for Q&A. The way that will work is I will take the questions you've asked and I will ask them to Luke and he will answer them. So at the bottom of your screen, you can see here on the screen, there's a Q&A button. So if you have any questions throughout the entire presentation, just go ahead and throw them in there. If it's at a point where I know Luke is about to answer it, I'll let you know that. Or if it fits what he's talking about, I'll go ahead and throw it out. But there will be a spot for Q&A. If you're having any issues, any technical issues or technical difficulty, you can use either the Q&A or the chat button down there, and that will come to myself or to Casey, and we'll get you taken care of.
All right. So let me move on. Let's just go ahead and get started into the nuts and bolts of this thing. So we're here today talking about shoulder pain, rotator cuff issue. And one of the things right off the top of the bat I like to ask is if anybody's had any shoulder pain in the last 30 days. Now, I asked that question myself. I have to raise my hand. I am a member of the Shoulder Pain Club. We'll talk a little bit about what caused mine and what happened, and then what I do about it. But that's the big question is, are you dealing with shoulder pain? Obviously, you took the time to sign up for the workshop. There's going to be an issue that you've dealt with that regard. One other piece of housekeeping that we didn't mention, you probably got emailed a little worksheet. In that worksheet, there are some questions. They're fairly simple questions, but we're going to try to answer those questions as we go through this workshop. So if you do have questions, again, throw them in the Q&A section, but we'll run through this and we'll get to some of those questions on the worksheet itself. And I'll tell you when we get to it and we need to address those things. All right, there we go. So let's start off by talking about what is the rotator cuff. So the rotator cuff, here's our gentleman there. Rotator cuff, we're going to talk about 3 different components. Number 1, the bones that make up the shoulder itself, the joint and what type of joint it is, and then the muscles that hold that joint together and make the thing move in concert with each other. We'll talk about that. Sometimes I have technical difficulties myself. Okay, so on the rotator cuff, let's talk about the bones. There are 3 primary bones. Well, the 3 bones that we talk about with the rotator cuff. The first one, the upper arm bone or the humerus, from the elbow up to the shoulder itself. It's that long bone right there. The second bone is actually the shoulder blade or the scapula that sits on the back of the rib cage. Connected to the shoulder blade is the structure right here, the collarbone or the clavicle. And those are the basic 3 bones that comprise make up the rotator cuff. Now there's one bone that gets really important on the shoulder blade that comes out to the edge right over here, and that's called the acromion. You don't have to remember that. That's just whenever there's some issues out there, almost always that acromion is involved. So those are the 3 bones that comprise the shoulder. And so the next issue is what type of a joint is it? Every joint in the body is going to have some similarities to others in how they're constructed. This joint, there's 2 pieces to it. So on the upper arm bone in the green area there, that's the ball, and that ball ends up fitting in to the second piece that you see on the right hand side, and that's the socket. So this is it's a ball and socket joint. The hip joint is similar. It's also a ball and socket joint. It's a fairly straightforward joint. The nice thing about this joint, the shoulder itself, the rotator cuff allows for more degrees of movement than any joint in the body. So it's more mobile than anything. When we talk about the knee extends and it bends back, similar to with our fingers. They extend and bend back. But the shoulder will rotate, it'll elevate, it'll come in and out, it'll come across the body and then back across. So it does a lot. It is a very mobile joint. So we talk about this ball and socket joint. I describe it to people as, and there's the socket, I describe it as thinking of it as a golf ball sitting on a golf tee. There is not a lot of surface area at the top of that tee for that ball to sit on. So the importance of that is we rely heavily on the muscles that make up the rotator cuff to hold that big ball in that little socket right there. So it's a joint that's very dependent on good muscle function, on good muscle flexibility and strength. If you do have an injury, one of them is going to be problematic, and it's going to make that ball sit in an awkward spot in that little socket on that little tee. So strength and proper function of the muscles of the rotator cuff get very important to proper function of that. And so let's talk then about the muscles. There are basically 4 muscles that comprise the rotator cuff. There are lots of muscles in and around the shoulder itself, but whenever we're talking about shoulder pain and loss of function and mobility, it's usually these muscles that are involved. And there's one of these that tends to be much more commonly involved than the others, and we'll talk about that. So the very first muscle is the one that sits right up on top. It sits right up here. That's called the supraspinatus, and you don't have to worry about remembering the names of these muscles. But that's the one that tends to get injured or compromised more than any other, and we'll talk about that in a minute as to why. The second one is below that, and these are both on the shoulder blade on the back. The second one's called the infraspinatus. So a lot of times the infraspinatus, it has a less tendency to get injured, but it has a higher tendency to cause pain. So if you've got, you're reaching around and saying that my shoulder hurts back here, a lot of times that's the issue that we're dealing with on that one. A smaller muscle right below it, it's still part of the rotator cuff. It's less likely to be involved or damaged, but it serves its function, and that's called the teres minor. Again, you don't have to remember the names of these things. And so on the back side, those are the 3 of the 4 muscles. Then we have to shift to the front side of that shoulder blade, and then we're looking here at the muscle on the front. So it sits right next to the rib cage as it comes across and attaches onto the upper arm bone. That one tends to be the one responsible for more of the pain on the front side whenever we have the complaint out here. And so it takes all 4 of these muscles to move in concert with each other. We need to make sure that they all have healthy extensibility and they have the right amount of strength. Some are going to be stronger than the others, just depending on the motions that we're doing. But those are the 4 muscles that comprise the rotator cuff itself. And so those are the things that comprise the unit itself. But there's a lot of other things that come into play whenever we're talking about how the arm moves. And we have to talk about all of them at the same time in order to effectively treat or to make that shoulder move. If you have an issue in one, it's going to create problems in the other side. So let's talk about those. First, the things that have to work together. Number 1 is the neck. There are a lot of muscles that come off of the shoulder and travel up to the neck as well. A lot of us carry a lot of stress and tension right here. Well, this big muscle runs up and attaches to the base of the skull, but it also comes all the way down out to the shoulder. So if there's a neck issue going on, if there's some limits in motion, if there's some pain, and we have some restriction that's going on here, then odds are we're going to have some limitation out in the shoulder as well. So the neck has to be a key part of what we look at when we're thinking of a shoulder issue. The second piece is the collarbone. The collarbone is actually the only bone that attaches the entire upper arm or the upper extremity to the body itself. It connects on the on the front side of the acromion on the shoulder blade, and then up closer to the front on the sternum itself. And so that bone does move a little bit. If that bone gets stuck, then we might find that we have some limits in movement with the shoulder. So we have to make sure that we're addressing that collarbone as well whenever we're looking at a movement or a pain issue. And then the shoulder blade itself. It seems odd because it's just going to sit on the back of the rib cage and move up and down. But anytime that there's an injury in, say, in the shoulder, that shoulder blade we're going to find that it gets really stiff. Say you get a little pain or something up in the arm. A lot of times we'll try to hold it up here and we'll protect it. Well, that limits the movement of the shoulder blade. So if we don't have good movement of that shoulder blade, then what we're going to find is that the arm itself isn't going to move well. So shoulder blade becomes really important with looking at issues with the rotator cuff and the shoulder. And then lastly, the rib cage. I know that seems odd, but the first one or two ribs play a key role in how the arm functions. And we'll look at that a little bit more in just a minute. But the first rib especially, there's some muscles that come off of the neck and attach right onto that first and second rib. And if they're tight or if they're short or if they're painful, then we're going to get a lot more of this pain and dysfunction on the outer part of the neck. And so then we're dealing with a neck issue and an issue there, and then even out into the shoulder, and it's going to limit what happens. So those four things really have to work in concert in order for the shoulder to be able to do what it needs to do. So now what I want to do, we talked a little bit about the worksheet. So now we're going to answer some of the questions on that worksheet. So the first thing is talking about, bear with me. All right, number one, what is the rotator cuff? Well, it's a group of four muscles, and what they do is they move the shoulder. So it's that four muscle group. The second question is the shoulder is a ball and socket joint. So if you have that worksheet, you can just fill it out in your head. You can, if you printed it out, you can write them down. If you're doing this on a computer and you have it opened up, it's a fillable PDF so that you can type those answers in there as well. Okay, and then the four areas work together for shoulder movement. It is the neck, the collarbone, the shoulder blade, and the rib cage. And if you don't end up getting all of these, feel free to email us, or later you can send it in the Q&A section and we can get those things answered for you. So how did I come to specialize in shoulder and rotator cuff treatment? Well, honestly, it came from working with my own problems. So I've been a physical therapist for, I'm into my over 26 years, going into my 27th year. And a lot of it is education that I've taken. A lot of it is things that I've seen with different patients, advanced training. But a lot of it, honestly, is dealing with my own. So in high school, I dislocated both shoulders during a football game. Now, football also is responsible for some neck issues and some back issues that I deal with, but that's a different story. That's for a different workshop. But I dislocated one shoulder on one play, went back to the sideline, they reset it. You have to wait out a play. I went back in the next play, and then somebody landed on the other shoulder and dislocated that. Well, at the time I was 16, 17, and at that age, I mean, you can bounce back from anything. It's no big deal. Fast forward 20 plus years and began to have a lot of recurring issues with the shoulder. I was a much younger clinician, therapist at that time. I did what I thought I should do. So I did some exercise, ultimately ended up having surgery on one of the shoulders. I was a bad patient, and I blew it out again. And so about that time, I started applying, we talked a little bit earlier about those four areas that we treat. I started applying that technique to what was going on with my shoulders. And so, yes, I still have some tears in my rotator cuff. I still have some bone spurs in there. I still have, we'll use the word impingement. I've still got some of that going on. There's still some tears in my cartilage or in my labrum, but I know how to address them, and I'll never play pitcher for the Rangers or the Astros or be quarterback for the Cowboys or the Texans, but everything that I need to do, I can do. And so that's my goal, is I want to be able to do those things and not be functionally limited with motion or with pain. So really it's that experience that taught me how to treat shoulders that are having their issues. From an education standpoint, so when I graduated in '94, physical therapy was a bachelor's degree. So I got that out at Texas Tech in Lubbock. I went on and I finished my doctorate in PT through the MGH Institute in Boston. I finished that up in 2012. Some of my achievements: I'm the author of Neuromuscular Dry Needling. We'll talk a little bit about dry needling momentarily. And I do lots of lecturing with that training series. And there are time to time at different colleges that I will do some guest lecturing. My clinical experience: I've treated or supervised over 500,000 patient treatments in the time that I've been a therapist. As far as dry needling, and I need to update this. When I first put this together, this is about a year ago, I've dry needled over 30,000 patients with over 150,000 needles. So I've learned a lot during my time doing this. I've learned things that work, things that don't work, and that clinical experience is really what lets us get to not only taking care of my shoulders, but being able to make a really good impact on people coming in with complaints of shoulders and rotator cuff. We have other workshops, one particular about low back pain, and we can do great work with low back pain, but the shoulder is uniquely particular in how we can make an impact on your daily routine, your daily life, because if you can't raise that arm up, if you can't use your shoulders, there's a lot that you are going to miss out on. And so it's fun to see the big changes that happen with people when we're dealing with rotator cuff issues. And so back to normal, the first steps. So we're going to talk about, is your problem reproducible? So normally this workshop is done in a live setting, where I can interact with different people. I can have people demonstrate how their movements are going on. Obviously, it's much more difficult to do this through an online webinar, but we're still going to work through this. So let's talk about traditional physical therapy. So when I graduated PT school and I was doing the things that we were taught and doing the regular stuff, maybe 25% were treated successfully. They came in with a problem. We dealt with that shoulder and they did fantastic, didn't have to have surgery, and got back to normal. 50%, they did okay. I mean, they got a little bit more active and they were doing their exercise and doing what they needed to do, but they still felt like, maybe at some point they'd need to have surgery. It just wasn't great. And then full 25% just didn't respond well. They went through a little bit of some therapy and ultimately ended up needing to go through surgery. So, and that's through traditional physical therapy. And I'm going to be honest, a majority of clinicians out there still operate on this traditional physical therapy approach. I like to think outside the box, and I like to apply a lot of different techniques to try to change what's going on in that shoulder. So what we're going to think about is using all four of those systems. So in that, I look at a person and dealing with a shoulder issue. First thing I want to know is, how's the neck moving? So we'll have a person identify that. What's that first rib doing? What's the collarbone doing? How's the shoulder blade? And so we look at all four of those systems. In that regard, when we do it that way, and we look at the whole upper body and sometimes the lower body as well, when we look at all of those systems as a whole, now all of a sudden, probably 90% of the patients that we can treat successfully, even if they have rotator cuff tears, even if they've got strains, even if they've got these things going on, we can treat those successfully and let them get back to a normal life. That being said, of the people who are watching this webinar, we had a good number of people that signed up. There's probably still 10% of you guys that you probably will need some surgery. If you're on here and you're having symptoms and pain, loss of motion, there's just some injuries that are too significant to change without surgery. That being said, 90% of people who come with these problems can be treated and treated successfully with improved pain, improved function, and getting back to the normal without having all these issues. So that's what we're curious when we're going through an exam. Again, we want to look at those 4 things, as well as what the shoulder and the upper arm are doing as well. And we want to see if we can reproduce that pain. And ideally, if we can reproduce it, if we can find a tender spot, a hot spot, if we can find a loss of movement, of strength, then there's hope. Because if it's reproducible, and bear with me on my technical savvy here, if it's reproducible, then we can kick that pro piece out, and then it can be reducible. So that's the good thing. That's what we're looking for. Can we find something to simulate that same, or to provoke your pain? If there is, fantastic. We've got a good shot at knocking this thing out. Okay, now we're going to go back to the worksheet again. We're going to answer some more questions. All right, so if you're pain, numbness, or tingling, a lot of shoulder issues end up creating problems tingling out in the fingers. It doesn't necessarily mean that there's pinched nerves in the neck. It can mean that, but a lot of times we find that tingling comes from tightness right through the front part of the shoulder. So if your pain, numbness, or tingling is reproducible, then it is reducible. And again, in the past 30 days, the worst pain I've had was what? So I'm going to answer that for me. I've had a pretty good month. Shoulder pain. I'm trying to think of what the activity would have been. It may have been while I was sleeping. I tend to be a person who sleeps like this, which we shouldn't, but that's what I do. And when I first move, then I have a little pain in there. And probably my worst pain was a 2 out of 10. So think through your last 30 days and think about what you were doing when that pain occurred, and how significant was it? Was it a 2 out of 10, a 3, a 5? Was it a 10 out of 10? And then jot that down. And so, and the third part is I have pain when it can be, and shoulders are so dynamic and they move so much that shoulder pain can come from almost any activity. Again, from sleep. Again, I sleep like this. So that creates issues for me. For some people, it's reaching overhead. For some people, it's lifting up. A big common one is trying to get a gallon of milk out of the refrigerator. So you get that long arm out there, and the milk can be pretty heavy. For guys, putting the hand in the back pocket. For ladies, putting on the bra, getting those arms back there, or fixing your hair, just getting up here. Hairdressers, a lot of times this is a challenging thing when they spend all day over somebody like that. So it could be that. For some people, it's something just as simple as getting up from the floor. All right. And then again, on the reproducibility, if any of these things are what's causing your issue, then we know that there's a cause. Some movement, some mechanical issue is creating this dysfunction, creating this strength issue, this motion limitation. And if that's the case, we can usually elicit a change, so there's hope. And so a brief, I'll keep this quick, discussion over what we can do about a problem. And it doesn't have to be a shoulder, it can be related to any problem. So we basically have 3 things that we can do when we're faced with a problem. So I'm going to use a pothole analogy in relation to the shoulder. So as we're driving down the road in our car, so I live on a road that has a lot of these pothole things. So I face that quite a bit. So one thing we can do, we can ignore a problem. And so ignoring a problem is definitely not going to fix it at all. And so we'll talk about the pothole in the road situation. What's this going to do? Okay, so number one, we can ignore it. If we ignore it, definitely the pothole is not going to go away. It will get worse the more that you drive on it. And over time, there will be damage to your car. Well, that's kind of the same situation with your shoulder. You're on here, you know you're dealing with some shoulder issues. You've probably ignored it for, listen, some people ignore shoulder issues for decades. And before they come in and we see them to try to help. So ignoring it definitely probably not going to change. It's not like old wine. It's not going to get better. It's just going to progressively deteriorate until we get to number 3. So number 2, we can alter it, and altering it, filling that pothole with asphalt. So what that looks like, okay. So we can come in and we can alter that pothole in the road. We can come in, and so what will we do? We'll just patch it. We'll just throw some asphalt in there. Now, unfortunately, you throw asphalt in a pothole, it's only going to last a little while, and that pothole is going to return. The more that car drives over and over that thing, we're going to have an issue again. So in the shoulder, what this represents is drugs, steroids, things of that nature, different types of injections, surgery. So when we're dealing with, and I don't care if it's the shoulder, if it's the knee, it's the hip, it's the back, it's the neck, whenever we're dealing with a pain, and we'll talk about imaging in a minute, whenever we're dealing with pain, we're dealing with a mechanical dysfunction that's creating a problem. And so you can get the drugs, you can get the injections, you can get the surgery, but if you don't address the mechanical piece, then once the drugs wear off, once the injection wears off, once the surgery is healed, you're still left with that mechanical issue. So if you don't address that, then you're still going to have the same problem. So the third thing that you can do with a problem is you can handle it. And so in that case, in our illustration, we're talking about just refilling that whole road. So in that case, we're gonna get rid of that pothole. We're gonna handle it. We're gonna repave the road, and this is gonna last a long time. And that pothole is not gonna return as long as they did a good job. So what did they do? They changed the mechanical or the physical properties of what was going on in the first place to let that car go down the road without having those issues. So here on handling it, it's talking about some natural treatment and learning to manage your own symptoms. So I mentioned that I have shoulder issues myself. I don't go to another clinician to have them deal with my problems all the time. Maybe once a year, twice a year, I'll have a little tweak, something that I need somebody to work a little magic on, and we'll talk about. But for the most part, once I address the mechanical issue, then I can do my part of my exercises. And I'm not the most faithful patient myself. I don't do my exercises every day, but I know when there's an issue, and I know when to go ahead and start working on those so that it doesn't become a problem. So I'm managing my symptoms, I'm keeping my pain under control, and it lets me continue to do whatever I want to with them. Okay, so we're back on the form, the worksheet. So the number one single biggest mistake shoulder pain sufferers make is they ignore it. And the 3 things that we can do if you're having shoulder pain right now is you can ignore it. Again, we've already talked about it's probably not going to change anything. You might have some good days and some bad days, but odds are that there's some mechanical issue that's creating the issue that you're dealing with. So the second thing is you can alter it. And that's what most of us do. We'll pop a few ibuprofen. We'll go. Maybe we get an injection if it gets bad enough. Ultimately, we may have surgery like I did. But until I handled number C, my mechanical issue that was going on, it really didn't change. So let me come back. What was that? So we're going to talk about the 3 main causes of shoulder pain. Now, there's a lot of potential issues, but there are 3 main causes of pain in the shoulder. Before we do that, I want to take a couple seconds just to talk about what normal imaging looks like. I look at a lot of imaging. I see a lot of bad stuff on imaging, and a person can have some bad pain, some bad symptoms. And I see people that come in with a normal imaging, normal x-rays, normal MRIs that have significant pain and have significant loss of motion. Conversely, I also see people come in with imaging that looks terrible. They obviously have rotator cuff tears. They obviously have bursitis and things of that nature. But, you know, their motion isn't that bad. Their strength isn't that bad. So we have to be careful when we're looking at imaging on what it actually means. So this is what a normal x-ray looks like. We've got nice clear space in between the upper arm and the acromion that we talked about right here. We don't see any bone spurs. We don't see anything crazy going on. So that's a nice picture of what's happening. Problem is, this shoulder could easily have a lot of pain and a lot of loss of motion and strength, even though everything looks good. So that gets us to, we'll talk about a little bit about some numbers. So MRI studies of adults who have no shoulder pain show that a full 20% have partial rotator cuff tears and 15% have full thickness tears. And that's important because these people have these tears, but they don't have any pain at all. In addition, in those who are 60 years of age or older, full half who have no shoulder pain or had injury had rotator cuff tears and they didn't even know about it. So the take-home message, the bottom line there is we can have tears in the rotator cuff. We can have wear and tear in our body. Again, whether it's the rotator cuff, elbow, hip, the back, the knees, we can have this wear and tear, but it doesn't mean that we're having pain. It doesn't mean we're having limitation. And it certainly doesn't mean that we necessarily need to go have surgery or unnecessary drugs or injections to take care of it. There's a mechanical issue that's going on for those of us who have pain. So we have to be cautious on that, on the imaging. A study on professional baseball pitchers showed that 40% of them either had partial or full thickness rotator cuff tears and had no pain. And they continued to play and they remained pain-free even 5 years after they finished that study. So again, the translation is do not panic. If your imaging shows a rotator cuff tear, it is not necessarily associated with your shoulder pain. So we're going to get to, with that thought, we're going to get to the vomit and the barf. So the vomit and the barf, victim of modern imaging technology and the brainless application of radiological findings. So imaging is fantastic. I think it's a great thing to look at. It's nice whenever the pain symptoms match up with what's going on in the imaging. But you don't, a good doctor friend of mine told me we never treat a picture. We're treating the patient. So treatment based on imaging findings alone without any clinical correlation, it just doesn't make any sense. We don't need to go fix everything that's got some wear and tear on it because we'd never stop working on this thing. So that's the vomit and the barf. Okay, now to the three main causes of shoulder pain. Number one, I'm always going to look at the neck first. So here we're talking about stenosis, arthritis, degenerative disc disease. With stenosis, we're going to start losing some height in those between the vertebra and the disc. And so we'll start seeing some issue of this closing down a little bit. That's going to compress on the nerves coming out of the neck. In this little diagram, and this is, let's see here. So this is on the picture on the left. And so I just show one nerve coming out to the right side. So we're talking about a right-sided shoulder issue. So you see the vertebra, you see the disc, and you see the vertebra below. And the gray areas are bone spurs. So anytime we have some stenosis, some aging, say we hit mid-50s on up, well, it can happen a lot younger than that too, but on average mid-50s, we're going to start seeing some wear and tear, some arthritis, if you will. And what happens is that closes down on the nerves as they come out into the shoulder. And then when that happens, we're going to start having some shoulder issues. So that's the number one problem that's the first problem is issues in the neck. On the picture on the right, so the picture on the right is actually opposite of the way the image is pointing. But what that's showing is with the vertebra and the disc and the vertebra below, that we start losing some height on the vertebra, and it's going to compress on the disc itself, the white and red part in the middle, and then it can actually push onto the spinal cord in the back of the neck, and that's where we can also start to see some pain out in the shoulder. So the neck issue, definitely a good first piece that we need to look at. Another part there is, and this is one of the 4 pieces that we look at, is the rib cage and the first rib. And so I've got a picture here that demonstrates where that first rib, so the green piece is that first rib. You can see that it comes off of the very first thoracic vertebra, and then it comes all the way around and attaches onto the breastbone, chest bone. It goes right below the collarbone. And if we look at the next picture, you can see what also travels right there. All of the nerves from the neck that go out into the arm run between that first rib and the collarbone. So I talked a little bit about, I like to sleep on my arm like this. So what tends to happen with that first rib is it can actually act like a bucket handle. So it can get stuck and it can come up a little bit higher. So when that happens, it puts a little extra pressure on these nerves as they go underneath the collarbone, because there's not as much space anymore. And so that then can create the pain out into the shoulder out here. So that's a key piece that we look at as well, as that first rib. You know, how is it moving? How is it functioning? How is it handling those nerves in that extra space right there? So the first rib gets very important. And then limited range of movement in the neck. Definitely we're curious about that. So there's 3 basic movement. It's the flexion, extension, or the up and down. There's a certain amount that we're expecting a person to have. The rotation, looking left and right. And when you're looking at this, you might try it yourself, you know, with the side with your shoulder. Is it tighter on that side, or is it moving better over here? The third one, the side bend, you know, trying to lean the ear down towards the shoulder. Is one side more problematic, or is it more painful than the other? And just as much as leaning that way or rotating or looking up and down, does that cause that pain to go out there? If it does, there are good odds that tells us there's some neck issues that's creating an issue out here. So if we're talking about treating that shoulder, we're going to have to start up there in the neck if we're going to have some good outcomes. So the second key main cause of shoulder pain is impingement. If there's a shoulder issue, probably there's going to be some impingement going on. There may still be a neck issue. There might be a first rib issue. There might be a collarbone issue, but odds are we're going to find some impingement out there. And so what is impingement? I've got 2 pictures loaded up here, and I'll show a little animation in just a second that demonstrates this a little bit better. But this upper muscle of the rotator cuff, this one that's highlighted in orange, is going to fall underneath this part of the shoulder blade right here, which we call the acromion. And if we turn and look from the front, you can tell there's not a lot of space for that in there. And what this picture even doesn't show is that there's a couple of bursa or shock absorbers, cushions, if you will, that sit in there as well. So if there's something that's irritating or inflaming this upper rotator cuff, then we're automatically going to lose space in here. And impingement, by its definition, it just means it's a lack of space for that muscle to do what it needs to do. So here we're going to have trouble reaching behind our back. Again, side sleeping on a raised arm. Here the space gets very small. And then if they're bone spurs, and they tend to happen where the collarbone attaches to the shoulder blade right here. Very common to see bone spurs coming down and into and even touching the muscle. And when that happens, you lift that arm up, it's going to jam that up into that, and it can create tearing of that area. Also on the impingement. So here's an animation that kind of demonstrates what that's going to look like. And this is going to last a little bit. I'm going to move forward into it a little bit. So here again is that upper rotator cuff, the supraspinatus muscle, and you can tell right on top of that is the acromion. Whenever that muscle contracts, as you can tell, we lose a good bit of space. We're going to rotate one more time here. Here we go. We're going to lose a good bit of space. Right. Well, come on. Hit the pause button. So when it's impinged and when that muscle is inflamed, we're not going to have room for everything. So that muscle where it attaches is going to bump up against the acromion right there. And that's where we get a lot of this pain out on the side. A lot of times that pain will also shoot down to the midpoint of the arm. Somebody that had registered for the workshop had talked about it wasn't so much there, that it was a little bit lower. And that is almost always because of some impingement that we may feel here. I can go in and I can dig around and I can make it tender there, but we're going to feel it a little bit further down. And that's because of the impingement. And so the third thing that we look at is poor posture. And this definitely comes across a lot better whenever we're in a live situation. So poor posture. If you're sitting at your computer or wherever you're at, and I'm going to turn to the side here. So poor posture, what I want you to do is to slouch way down, okay? Then I want you to sit nice and tall, throw your chest out, your shoulders back. When you're in this position, what I want you to do is lift your arm straight up and down and see how well you do with that. You do one, do both of them, okay? Then what I want you to do is to slump down. And then I want you to do the exact same thing. One arm, both arms. And now you're telling yourself, wow, I just lost a whole lot of motion. So posture plays a critical role in function of the shoulder and the arm. It can make almost probably a 40% drop if you have a slouched forward head posture on that arm coming up versus you're sitting nice and tall. So posture is critical. So a little bit of information about the effect. We talked about the importance of the neck. When we talk about a slouched posture, here's a picture of a guy or gal, whatever, playing on their cell phone. So with the head upright, there's about 10 to 12 pounds of downward force coming through the head into the bottom of the neck. And the further out that we go with our posture, the closer we get to here, all of a sudden we move that center of gravity way forward. And now all of a sudden that 10 to 12 pounds has jumped up to about 60 pounds of force through that area. And that's the area where it has a big impact on the function of the nerves and muscles coming out to the shoulder itself. So posture is incredibly important. I can't stress enough a person, if nothing else, step one, you've got some shoulder pain going on, think about your posture, throw that chest out, tuck that chin in, and see what impact that will have before you do anything else. So third part, definitely posture. Okay, and I think we're back to our worksheet. The guy there. All right. So the top 3 common causes of shoulder pain. 1, it's a neck problem. And we talked about the importance of the neck and how it relates in the function of the shoulder. Number 2 is, or B, impingement. It's a direct cause out underneath the acromion, between the acromion and the biggest of the rotator cuff muscles, the supraspinatus. And then C is going to be posture. And posture and neck function go hand in hand. Again, the further we get here, the less motion we can get. We change that posture and we automatically get some improvement. So what does successful natural treatment look like? Number 1, if you've been to a clinician before, and it doesn't matter who it is, if they're not putting your hands on to move your shoulder and the joints around there, and if they're not doing that, then you're probably missing out on a good bit of what can really be helpful as far as treatment for the shoulder issue. And again, it needs to look at all 4 pieces of the puzzle. There's definitely some stretching that's involved, but just as much is the importance of the strengthening to get the muscles back to where they need to be. So I mentioned that this is a mechanical issue. There can be a neurological component, absolutely, but more often than not, it's a mechanical issue, whether it's a posture issue, whether you've got a limitation of movement. And so we have to, number one, do some stretching to restore normal movement, but then we have to get the strengthening back so that we can maintain that. We got to develop that muscle memory so that the neck can continue to do what it needs to do. We can keep that first rib down where it needs to be. We can keep the shoulder down where it needs to be so it can come up. So the strengthening is on B. And then C, either dry needling or a class 4 laser. So we consider that there are 3 phases of the healing cycle. Number 1 is during the acute cycle of the pain. We need to knock out that acute sharp pain. We've got to get pain knocked down to a good functional level so that we can move on. Whenever I treat a patient, I don't want to spend 12 sessions just dealing with pain. I want to get that pain knocked down first treatment or 2 so that we can move on. Dry needling, so to explain dry needling, we use acupuncture needles, but we're going after very specific anatomy that's either in a low-grade spasm that's very tight, and we can use that. And usually 1 or 2 sessions of that pain is dropped significantly, and we can move on. Extremely important treatment tool. If not that, some people just are very phobic or afraid of needles, and that's fine. There's what's classified as a class 4 laser that can really penetrate into those tissues and really break that down as well. I feel like dry needling is quicker and more responsive, but again, that person who's not comfortable with needles, the laser, and this is the level of laser that they use with veterinary, with horses. So we can really get in there and break some of that tension down. So you need something to break that cycle, and it's dry needling or a class 4 laser. So I wanted to throw out just a few testimonials of some folks here. This is another one of our physical therapists, Kat, Donna, and all these folks have given us permission to use their information. She came in and was having a real hard problem with her arm. She's now pain-free, and she's gained 100% of the use, and really recommends our treatment approach and did remarkably well. Nancy is probably the sweetest person in the world. Nancy came in. I looked at Nancy's imaging, and her imaging was pretty bad. By all rights and reasons, she should have gone and had a complete shoulder replacement. I had a talk with her and told her, we can go through our treatment approach. I can't guarantee that you're going to get 100% back, but if you stay with it, you'll get there. When she first started, she could barely lift her elbow away from her body. And when she was finished, she was able to reach all the way up and do anything that she wants to. She still has to do her exercises. She still has to manage her problems. But Nancy was a remarkable success story. Martha, very similar. Had a significant pain situation, but using our treatment approach of treating those 4 pieces was really able to get that pain knocked down and get back to what she wanted to do and needed to do. So very good success story with her. And then the last one, one of my favorites. This is Elaine and her son. Now, Elaine wasn't here for her shoulder. She came in for treatment of her knee, but I wanted to include her because she's just so wonderful. Elaine takes care of her son who's got some mental issues, and so her knees are shot. She really should have both of them replaced, but we've used our approach. Our approach isn't going to make her knees heal, but the approach lets her function, lets her take care of her son, and it has made a huge difference in her life. And so, again, she wasn't a shoulder, but I wanted to include her and Jeremy there. So you've stuck through the workshop this far. You've obviously got some shoulder issues going on. And so this is what we want to do next. There's some people who are going to want treatment right now in the clinic. I will tell you that throughout this whole COVID-19 thing, we are an essential service. We take all the necessary precautions and steps to prevent any issues. We're sanitizing. We're doing all of the things that we're supposed to. People are still in pain. People are still having problems. The reason why we are still considered essential and we're from the get-go is because the CDC felt like it was important for us to stay open so that people could come see us for their muscle aches and muscle pains and their musculoskeletal issues, and not have to bog down the emergency rooms or the primary care docs, the orthos. So we've been treating all along. Now, you may still have an issue that you don't want to come in, and I understand that. So we have a way using telemedicine that we can get a good bit down the road with either a free screen, which we'll talk about in a second, or with actual treatment. So we can go about this in either way. But what I want you to do is go to HaynesTherapy.com/contact, and in there, or you can call our number, and HaynesTherapy.com/contact. And in there, what we're going to find is a link to reach out to us to set an appointment, either to do a free screen, or if you want to jump straight to an evaluation, we can do that. So there's a place for your name, your email address, and then if you want to include a subject and a message, that'll help us know what we're looking for. But again, the address, HaynesTherapy.com/contact. And so what my offer is, why am I having this webinar, this workshop series? Number one, I am going to offer a free consultation. You went to the trouble of coming online and listen to me ramble for right at an hour. So I want to tell you a little bit about what a free consult is. With that, I'm going to look at some certain movements, and I'm going to feel your shoulder, and we're going to determine what might be causing your rotator cuff and your shoulder pain. We want to see if there's something that can be done to heal it naturally. Again, my experience is 90% of people, we're going to be able to make a good functional improvement with your movement and your pain. And I'll give you some tips. At the end of that, if you decide you want my help, then I think that's fantastic. If you don't want to do that, then I'm not going to strong arm you and try to sell you on anything. I just want you to have the information on what I think is going on and what you can do to handle it. Not everybody needs to come in and be treated. I see quite a few people just for a free consult, and we look at it and I show them a couple things and they go take care of it on their own, and that's perfectly fine. So let's talk a little bit about the difference between a free consultation and a full physical therapy evaluation. The biggest difference is the amount of time. So a free consultation, and I don't let people just off the street walk in and me just do free consultations. But on this workshop situation, that's what I do. We'll take 15 or 20 minutes. We're going to see if we can determine a potential cause of what's causing your pain or your limitation. And we're going to talk about what successful treatment might look like. And I'll probably even go ahead and give you a couple of tips on what you can start working on at home and see if it'll help. If it'll help, fantastic. If not, then we can talk about what is a full PT evaluation. A full PT eval is probably going to take anywhere from 45 minutes to an hour. And there we're going to drill down and we're going to identify the cause of what's causing your problem. And we're going to go ahead and apply successful treatment. So if you're in significant pain, odds are we're going to pull out that class 4 laser, or we may even pull out some dry needling. We're just going to work through what the pain problem is. At that point, we're going to go ahead and set up a plan of care to treat your condition. There are some people that want to be, and I'm going to be honest here, some people want a quick fix in a session or two and be done. There are some cases where that does happen. If this is a situation that's been going on for 6 months, a year, 2, a decade, 1 or 2 times of treatment is not going to change it. It's going to take a full committed, probably 4 weeks of treatment to get it to where it needs to be. Because again, we have to change that mechanical problem. That's the issue that's creating the problem. So that's changing those habits is the big part. So that's the difference between a PT evaluation and a free consultation. I'll tell you that I have plenty of slots. I've got Ashton on the line here. Casey's on. If y'all have questions, through the Q&A portal down there. If you want to type into them and say, hey, reach out to me. Let's see what we can do. then you can do that. I've got slots for free consultations and slots for evaluations. If you'd like to take one of those slots, indicate it either in the chat session down there or in the Q&A. So here I'm going to ask Ashton to jump back in and see if there are any questions that I didn't cover. I probably covered a lot since I talked for a good solid hour.
You did. I do have one question. Judy wanted to know the difference between dry needling and acupuncture.
Okay, so a very good question, a very common question. So in acupuncture, what an acupuncturist is trying to change is your chi, your life force, your energy flow throughout your body. So they're going to, with a shoulder issue, they're going to look at certain meridians that run from the top of your head down to your foot. I've studied some acupuncture. I'm going to be honest, I do have people who do acupuncture and they do okay with it. But what I'm looking at with dry needling is, so we talked about the 4 muscles of the rotator cuff. I want to go to specifically needle into that muscle itself. The one that's in a low-grade spasm, needling into that is what gets it to release. And there's a lot of different structures around there that we can affect by using dry needling. So the difference is in, honestly, it's Western medicine versus Eastern medicine. I don't know anything about your chi, and I don't want to know anything about your chi or your yin and your yang. But I do want to know about your supraspinatus and your impingement. So if I've covered any of the other questions, I will make this available. I will probably send an email tomorrow, a copy of this on our YouTube channel, that if you want to watch it again, you can. If you have some questions, feel free to email. My email, it's luke@hainstherapy.com, or some of the emails. I know we've hit you with a lot of emails. So respond to any of those. And if we need to give some more information out, we can. I appreciate your time coming in and listening to me ramble. I hope you got a little bit of some helpful information out of this. And if there's anything else we can do, feel free to reach out and let us know.